All right, so we are going to talk about another type of injury that can happen and look at how it can repair itself, and that is fractures or breaks in the bones. And so, what is this process for repairing fractures? So, the first step is our hematoma formation. So a hematoma is a collection of blood. Typically we see it under the skin surface, but in this case we're actually seeing it within the bone itself. So you can see in panel A here as we have this blood forming, puddling or pooling within this region of the bone. And it's kind of being contained here as far as the periosteum is keeping it in as much as it can, but any breaks in the periosteum and it will actually leak out as well. So you get an increase in the blood, which will increase the signaling for chemicals to come. Without having things come to heal the area itself, we actually would have necrosis of the bone ends or dying of the bone ends. So it's needed for us to be able to do that. So we're forming that hematoma. It's signaling for other chemicals to come in the inflammatory process because otherwise the tissue or the bone would die. So then we move on to our second step. The second step is the fibrocartilaginous callus formation. So cartilage is formed at the fractured site. The bone begins to form directly around that area, and usually it's along the periosteum layer. So we've got bone that's starting to form or cartilage that's starting to form. Then we have a lot of growth of blood vessels. So we get a lot of vascular growth that is coming in order to bring more nutrients to the area. And really, when it comes down to it, micromotion at these fracture sites is really vital for us to have this callus formation. So we need to make sure that there are some micro movements that are happening in order to continue this bone growth. The active cells that we're talking about here are all of our inflammatory cells for like the phagocytic cells and such, and also the healing cells like the fibroblasts that are laying down new tissue, as well as osteoblasts. And osteoblasts are the cells that are building new bone. So osteoblasts build bone. Our next step in the repair of fractures is the bony callus formation, also known as the hard callus formation. So we had soft calluses forming on the previous slide, and now we've got hard calluses forming. So the cartilage that's at that fractured site is now beginning to calcify and become harder. The calcification continues until the bone ends ultimately are reunited and are joined from inside wherever the break was. There's still an increase in blood flow to the area here as it improves the healing. It's bringing more nutrients and clearing away debris. And then we have our fourth step, which is the bone remodeling phase. And here, the hard callus is remodeled into mature bone. So what once was kind of joined together in what we saw on that last page, in which you can still see where the fracture was, it starts to remodel into a new mature type bone and actually is more smooth in nature. We also have a lot of osteoclastic reabsorption that's happening. So osteoclasts will break down bone. So it's reabsorbing some of those extra layers of bone in the process of this remodeling nature. Blood supply starts to return back to a normal amount. And then mechanical forces are really needed for us to be able to do this remodeling. So we need to have mechanical forces and in this process, which is why often after you are out of a cast, they will put you into a walking boot. So they still want to protect it, but they want you to be able to put weight on it in order to start remodeling that bone. And that's what the walking boot is for. So here's an example. Here we've got a picture right here of where the break was. And then we started to reform. We had the soft callus formation, and now we're at the hard callus formation here. But you can see that there's still this break. You can tell that there was a fracture to this bone. But as we walk around on it more and put more weight on it, it starts to remodel. Those osteoclasts will break down the bone. Osteoblasts are building up bone in new areas, and it works together to be able to remodel it so now it's nice and smooth and has integrity. So, we've talked a lot about ibuprofen or other non-steroidal anti-inflammatory drugs on the inflammation process. And we've talked about how it does tend to delay healing or extend the healing process when we're dealing with inflammation in general, any kind of an injury. And this is actually a great picture of what it looks like when we're trying to do bone formation and bone remodeling again. So what we can see going across here, we've got no drug was used in this circumstance, and then different types of non-steroidal anti-inflammatory drugs were administered. And I believe this is in a mouse femur is what was broken. And we're looking at that healing time of 2 weeks, 3 weeks, and 4 weeks of what would these things look like. So just to put a little context of things, the red that we see right here, that is bone. When you can see this orange to reddish color right here, this is our cartilage, our calcified cartilage. The cartilage that is not calcified is these darker blue areas in here, almost to a deep purple. And the lighter blue of what you can see is sometimes muscle, but a lot of it is just fibrous tissue that is building up. So you can see that lighter blue that's right above that. So when we take a look at no drugs given, so this is no non-steroidal anti-inflammatory drugs given, we had the break right here. It's starting to heal. We build up that fibrous tissue as it's trying to start to heal the process. Cartilage is starting to form. It then begins to calcify at around 3 weeks or so. And then by 4 weeks, what you'll notice is that that calcified cartilage or the cartilage has now fully calcified. So here it was still forming as the cartilage you can see in the dark blue. And here, as it's more of this orange to red, we now have calcified cartilage. And ultimately that will start to reduce into bone as well. So what happens when we give drugs? Well, what you'll notice is that we get that cartilage that's forming, but that cartilage is not calcifying over time. We also get an increase in that fibrous tissue instead of having that calcification that's happening. And you can see that across every single one of these conditions in which medications were given. And I feel like that is a really powerful picture of how this was occurring and delaying the healing process, where you can see like good healing taking place when there's no drugs administered. But in every other case, when drugs were administered, at 4 weeks, it was nowhere near the healing process that it was with no drugs, and was in fact kind of more similar to what we saw after only, like halfway through. So I think that's just a good, powerful visualization of that. I also want to show you this same type of a thing in which we're looking at these different drugs, right? Having no drug versus other types of non-steroidal anti-inflammatory drugs. And again, we're looking at 2 weeks. This is 4 weeks and 8 weeks on the bottom right here. With no drug, you can see there's a little rod in this little femur of our mouse here. But you can see that the forming of the bone is coming, and you can see that calcification that is occurring on either side of that rod. But now when we start going to where we're looking at it with our drugs on board, you'll see in each case, this is not forming. And in this case, you can see that the break is still completely there after 8 weeks. with this particular drug, whereas here we've got fully calcified, we've got bone reforming, we've got good integrity and continuity of the bone itself. So again, just showing you what these differences look like when we are delaying our healing process by taking things like ibuprofen or other non-steroidal anti-inflammatory drugs. All right, I'm going to transition us for just a little bit, and we're going to talk about some stretching and myofascial release. I've got a little video. ASAP Science is one of my favorite video platforms that you can find on YouTube, and we've got one that's just going to talk about stretching and self-myofascial release.
More than 10 million sports-related injuries occur in the world every year. To avoid this, athletes and coaches alike are using a variety of pre-competition techniques to decrease injuries and increase performance. But what does science tell us about stretching and warming up? Many studies have looked at how stretching can affect athletic performance, and it turns out it depends on the activity. Sports such as figure skating and snowboarding, which require a wide range of motions to impress the judges, certainly benefit from an athlete's flexibility. But for power sports like speed skating and bobsledding, too much stretching may actually cause a temporary decrease in muscle strength. The overstretched muscle becomes less responsive and can stay weakened for up to 30 minutes. Although athletic competitions can be strenuous, there's little evidence to suggest that stretching before or after a competition decreases muscle soreness. Some studies have even noted that extreme flexibility can lead to an increase in the range of stretching without pain. And if you can't feel pain, the body doesn't know when to stop pushing. As a result, injuries can occur. Another large study of athletes found that the least and most flexible participants were 2.5 times more likely to incur an injury. So when it comes to flexibility in competitive sports, it's most beneficial to be moderately flexible. A well-designed warm-up is also extremely beneficial. The term itself comes from the positive effects of raising the temperature of your body before a competition. Slowly increasing physical intensity prior to a sport increases muscle temperature, ultimately allowing your muscles to contract more forcefully. More forceful contractions equals more strength and power. Furthermore, slowly adding movement to your muscles opens up the blood vessels, allowing blood to flow more easily throughout the body and decreases the strain on your heart. Finally, as your blood temperature increases, your blood cells actually hold less oxygen. This loose oxygen is then free to be used by your muscles, increasing overall endurance. Science says it's important not to overstretch it when it comes to flexibility, but physically warming up your body before each specific sport might help you burn the competition. Don't forget, we have a new video out every day during the Olympics. Can't wait? Our amazing partners at the CBC already have 5 of the videos up now for you to binge on. Just head to cbc.ca/Olympics/Science Says to watch them before anyone else. Link in the description. But we also want to know your questions for this special series. Use the hashtag ScienceSays and let us know your burning Olympic questions. And subscribe for more awesome science videos.
I will note that on YouTube, ASAP Science does have a lot of Olympic and athletic type posts right from around this time period. So you should check them out on YouTube, and you can actually learn a lot about the Olympics and training. It's kind of cool. So let's talk. We're going to talk about stretching. We're going to talk about stretching and how this all works physiologically within the body. We're not going to talk necessarily about how to stretch. We tend to cover that in the strength training, conditioning, instruction class a little bit, but we are going to talk about the anatomy and physiology of our stretching, looking at Golgi tendon organs and muscle spindles. And we're going to talk about the autogenic inhibition and the reciprocal inhibition. All right, so let's talk about Golgi tendon organs, GTOs. As far as their location is, think to yourself, what is this location? They are found at the junction of the muscle bellies, between the muscle bellies and the tendons. So they're right there at that junction when it's going from musculature to the tendon. When are they activated? Well, they're activated when muscles are contracting, especially under forceful contractions. And what ends up happening? This is our autogenic inhibition. So let's take a look at what this actually means. So when we have contractions that are occurring, and we can sense that at the Golgi tendon organs, So you can see that right up here where we're sensing them right as this junction between the muscle and the tendon. It's going to send a message, and it is a reflex. It happens without it ever needing to go to our brain. It is not involving our brain at all. It actually is just going in through interneurons within the spinal cord. So we've got a neuron that comes through, goes in the back of our dorsal root ganglion and through the dorsal roots, and then it right here has an interneuron that comes and feeds into our contraction here. So when we have our relaxation here, so it inhibits, it's an inhibitory neuron that will relax this muscle. So when we contract and we sense that in the Golgi tendon organ, it sends this message through to an inhibitory neuron, which will then inhibit our messages that are going out to contract the muscle and actually have them relax. So you might be asking yourself, if I'm contracting a muscle, why on earth would I want to be relaxing it? That doesn't even make sense. Well, really, it's a protective mechanism. Whenever the tension is getting too great of a contraction, it allows us to drop the load. So imagine like you're trying to hold a contraction for a really long time, and you're like, oh, I'm trying to hold on, and you're just holding it stable like in an isometric contraction. And it's putting too much stress on the muscles, and then it's actually going to start damaging the muscles. It will start to relax the muscles so that you'll drop the load, and it won't cause damage to the actual muscle fibers itself. It also allows us to spread the workload across more evenly across the different motor units within the muscle. So instead of just doing it like if we've got contraction coming through one realm, it's going to help to relax it and maybe activate other motor units that are being fired. So we're thinking way back to XPhys, right? And we're looking at them how we have multiple motor units that can come down to one muscle. So through contraction, we might end up relaxing some and then allowing us to spread that load more evenly to other motor units as we're functioning. If you haven't taken XPhys yet, it's okay. Don't worry. All right, so those are our Golgi tendon organs working off of our autogenic inhibition, that when the muscles are contracting, it's sensed right there at that junction, and then it ends up going through a inhibitory interneuron, which then connects to our efferents that are going to muscle contraction and causes them to relax. So now let's take a look at muscle spindle fibers. So the location of these, instead of being at the junction between the muscle and the tendon, it's actually within the muscle belly themselves. So in the fatty portion of, not fatty, but in the larger portion of the muscle belly itself. And when are these activated? Well, you might remember this is when muscles are stretched. So they are activated when muscles are being stretched. And what ends up happening is we have a gamma loop activation. And what it does is when the muscles are stretched, it ends up contracting the muscles. And it does it through the intrafusal and extrafusal fibers that we have, so inside and out. And so we've got a picture right here. So we have a stretching of the muscle. You can see it's like the arrows that are pointing out and drawing it in the opposite directions. When this is stretched, again, it's a reflex. It does not involve our brain whatsoever. It comes through the spinal cord and directly comes through and activates the contraction of that muscle. So you might be asking yourself, why on earth, if we're trying to stretch a muscle, would we want to contract it? Well, it's really a protective measure, right? So when the muscle is all of a sudden rapidly stretched, so they're activated the more stretching that's happening, right? It's not at the little, they increase in firing rate the more that you are stretching the muscle. So when you've got a lot of firing rate of these muscle spindle fibers, because there's a lot of stretching happening, it might be damaging to the muscle, and it might actually end up tearing the muscle. So it will try to contract it to avoid that damage from occurring. So again, it's a protective mechanism in order to not damage the muscle itself. All right, so when we're looking at it, what's happening with our muscle spindle fibers when we are stretching? You might be asking yourself that. Like if we're trying to stretch it out, are we defeating the purpose because we're activating those muscle spindle fibers? It's a great question. And in fact, what ends up happening is that with a constant stretch, what ends up happening is that it habituates or desensitizes the muscle spindle fibers. So what it means is that the more that we're doing stretching and holding it underneath like constant pressure and constant stretching, it will desensitize those muscle spindle fibers and it'll decrease the firing that's happening. It basically resets the threshold for firing and it allows for that muscle lengthening to actually occur. All right, we're going to change focus right now and talk about reciprocal inhibition for just a moment and how we might be able to apply this with stretching as well. So the traditional example of reciprocal inhibition is that you step on a tack. Okay, you step on a tack and you get a sensation of pain. That sensation of pain, it's a reflex. Again, the reciprocal inhibition is a reflex, so it happens automatically without our brain needing to control it. And it feeds back into the spinal cord, and here it will send out messages to do two different things. One, it will contract some agonist muscles and relax antagonist muscles. So for instance, what would be happening here, because I am stepping on a painful stimulus, I want to make sure I get rid of that stimulus by lifting up my foot. So it will contract my quads to give me knee flexion, and it's going to release or relax or inhibit my hamstrings so that it can allow for that contraction to happen. Okay, so that's kind of the example of what it's going through. It also just works when we are walking to be able to alternate back and forth so that we are not trying to contract both our agonist muscles and our antagonist muscles at the same time. So we see our we experience our painful stimulus. That gives us pain sensation through here. What it does is it'll inhibit our backside of our muscles, our hamstrings, in order to relax so that it can allow for the contraction of our quadriceps to give us this knee flexion to be able to lift up and remove ourselves from that painful stimulus. So this is what the reciprocal inhibition is. So now, how is autogenic inhibition and reciprocal inhibition related in our stretching? Well, one way that we can use these to an advantage, the autogenic inhibition and the reciprocal inhibition in stretching, is through what's called proprioceptive neuromuscular facilitation. So proprioceptive neuromuscular facilitation. We also know that as PNF. So you'll see that a lot of PNF, and that's what it stands for. There's a couple of different kinds of PNF. One is called the Contract-Relax method. So what it is the PNF is always assisted stretching, and that's either from another person or potentially you could be doing it through the use of a strap if you are doing it by yourself. But to do it most accurately, it's usually with an additional person assisting you in the stretch. And you can see that in the picture right here. The Contract-Relax method, you get contraction of the target muscle. So whatever we're trying to stretch. So right here in this example that we're going to be seeing, they are trying to stretch the hamstring. The person assisting is going to ask her to contract her hamstring as much as she can, which will activate the Golgi tendon organs. And that will give that feedback reflex through autogenic inhibition in order to actually have that muscle relax. And then when it's relaxed, we can now stretch it into a further stretching pattern. So we contract that muscle in order to activate those Golgi tendon organs. And then when we relax, the person assisting will push that leg into a more stretched position for the hamstrings. Now you might ask yourself, like, is this an effective way to be stretching? Well, if it's done prior to exercise, so if you're doing it before exercise, it actually decreases the performance in your maximum effort that you can do with those muscles, whatever muscles you used it on. And that can last for up to about 90 minutes. So there is a drawback from PNF in that it does decrease your performance in your max effort, your max strength that you have, when you are doing it before exercise, and that can last up to about 90 minutes. However, if you do it consistently and after exercise, so not before exercise, but afterwards or just during rest time periods, it does increase athletic performance and the range of motion. So what they recommend is doing at least 2 sets of these types of stretches for the different body parts you're trying to do per week in order to see this. So it has to be consistent and it has to be over the long haul for it to work. I'm going to actually show you a video now of what this Contract-Relax PNF might look like. We got our little Australian guy that we have right here. He's kind of funny to listen to.
Let's now address the Hold Relax PNF stretching technique. Before we start any sort of partner stretching, we should be setting up some appropriate communication terms with our client and between the trainer. We're going to set a 1 to 5 stretch scale where we want to make sure all of our stretches are lying between the 3 to 4 range. To start this technique, we're going to ask our client to raise their leg to put their hamstrings through a passive range of motion stretch of around about that 3 to 4 scale. Make sure you as a trainer are setting yourself up appropriately so you do not injure yourself. Let's put our client now through our passive range of motion stretch. How's that feeling there?
Yeah, that's good.
What sort of numbers are we at?
3.
Fantastic. We're going to hold this for approximately 10 seconds. Eight, 9, 10. From here, we're going to ask our client to isometrically contract towards the trainer for 6 seconds. Off we go. How's that rating there? Do you feel it around about 3 or 4? Fantastic. 5, 6. We're going to ask our client to relax for a couple of seconds and then further move into a passive stretch of a rating of about 3 or 4. How's that feeling there?
Yep, 4.
Fantastic. We're going to hold this stretch for another 10 to 15 seconds. (14, 15) and relax. Once you have completed this particular technique once, ask your client to relax for a couple of seconds and then you can repeat it 2 to 3 times.
All right, so that's the Contract-Relax. We also have a Contract-Relax-Antagonist-Contract. So we're going to show this, and this one he makes a little mistake on his filming. We'll give him grace.
Let's talk about the Let's talk about the hold relax with agonist contraction PNF technique. This is seen as the most effective PNF technique due to the autogenic and reciprocal inhibition of the muscles involved. This technique starts off with a passive stretch through the hamstrings, in which we're going to be stretching today, followed by an isometric contraction of the muscles stretched, followed by the muscles that are going to go through a hip flexion activated whilst going through a larger range of motion with the passive stretch. Let's get into it. First, we go through a passive stretch, making sure that the range is appropriate. How's that feeling there?
Good.
Let's hold this passive stretch for 10 seconds. Nine and 10. We're then going to ask our client to go through an isometric contraction of the agonist muscle that we're stretching. So your client will then be pushing against you while you make sure the leg doesn't move. This will last for 6 seconds. Want to just push against me for 6 seconds? Off we go. Five and 6. From here, we're going to ask our client to go through hip flexion actively themselves while we also assist with hip flexion to increase the range of motion of the stretch. So would you like to just actively pull your leg towards yourself, going through hip flexion, and I will assist. We hold this for another 10 seconds. Nine and 10. And then ask our client to relax. And if so, this technique can be repeated 2 to 3 times to increase the range of motion at the joint.
All right, so what we saw there is we had the contraction of the hamstrings when he was pushing against him, then was asked to relax so that it would cause that autogenic inhibition. Then he was asked to actively flex his hip, which would contract those quadriceps, or well, not the quadriceps, but the psoas and iliacus, as well as other hip flexors, that it would activate all of those antagonist muscles while we still continued to push the stretch through on the hamstring. So again, this is called the Contract-Relax-Antagonist-Contract method, and it is a type of a PNF stretch. So here, what we were doing was combining both the autogenic inhibition that we saw with contract-relax, and when we are contracting the opposite muscles, those antagonist muscles, it's going to relax those target muscles that we're stretching because of the reciprocal inhibition. Now, the question is is this really what is happening? And it's a good question to ask. This is the physiology that has been proposed, or one of the ideas of the physiology that's proposed on why PNF stretching works. But really, it's a little bit under-researched, but we think it may contribute. There are some other theories, though, behind PNF, and I just thought I would kind of share them with you. So another one is stress relaxation. So when we look at muscles and tendons, they tend to have both viscous and elastic properties. Elastic is kind of that, just being elastic in that it can come back into shape. Viscous is more like a tougher, I'm trying to think of a word to describe it, in which it's just like a more sludge-like response to things. So they exhibit both like the ability to stretch and the ability not to stretch. And the viscous material is usually what is resisting when we are being stretched. And it loses the ability to resist that stretch over time when we've got constant stress applied. So the viscous material is trying to keep everything in the shape that it is. It's responding very slowly to it. But when we continue to press over time, it loses that ability to resist that stretch over time. And ultimately, the muscle starts to slowly increase in its length. It's called creep. So it slowly starts to increase in length over time of constantly applied pressure. Another theory behind the proprioceptive neuromuscular facilitation, or PNF, is the gateway control theory. So here's what I want you to do. I want you to close your eyes for just a moment as you're listening to this. Close your eyes, and I want you to imagine it is 2 o'clock in the morning, 3 o'clock in the morning. You have been asleep for a couple of hours, and you ended up drinking a little too much, we'll say water, before going to bed. And you are woken up by your bladder at this 2 to 3 o'clock in the morning. And you're like, oh, I really need to go to the bathroom. I'm so tired though. I don't want to get up. I don't want to wake myself up, but I really need to go to the bathroom. And you have this thought over in your head for a while before you finally decide, I can't wait. I'll end up peeing the bed if I don't go now. But you know that if you get up and turn on the lights, that will actually activate your brain to wake up more. So you're going to choose to leave the lights off as you're walking through the house. And as you're walking through the house, you're walking into like the living room to go and get into the bathroom, and someone has moved the coffee table unbeknownst to you. And as you're walking, you hit your leg straight into that coffee table. Now, the first thing that's going to happen is probably an expletive will come out of your mouth, right? Or a gasp or a yell or something like that. But what else are you going to do at that moment to try and deal with that pain? Now, if you're like me and like most people, one of the first things we do after the expletive comes out of our mouth is we grab and put pressure in that area. You can open your eyes now. So, looking at the way that receptors work, the brain cannot process two signals at the same time when it's having like pain stimulus come in. So what happens is there's different types of stimulus that can happen. We have pain nerves. Pain nerves are very small and they are unmyelinated. They do not have that sheath around the nerve. If you've taken XPhys, you know what that means. If not, you'll learn about it later. It's fine. But they're unmyelinated or just little bits of myelination that's there. Pressure nerves are larger nerves, larger receptors as well, and they have a lot of myelination. And myelination dictates the speed at which messages are sent, right? So if I have myelination, messages are sent faster versus if I have nerves that are unmyelinated, it takes a longer time for those messages to be sent throughout the body. Well, we have these two different signals that are trying to come in. When we are experiencing pain, but we instead put pressure into it, that pressure will override the sensation of pain, and we will experience the pressure instead. So when we banged our shin up against the coffee table and we put our pressure by like holding onto our leg and putting a lot of pressure on it, we activate those larger receptors, which will in turn travel the messages through these large and myelinated neurons going back to the brain, and the sensation that we will feel, because it's going to get there more quickly and it's going to get there with more power, is the pressure instead of the pain. So it actually makes us feel better. Now, how do we apply this into PNF and stretching? Well, the force of the contraction that we're doing in PNF is seen as kind of like a noxious stimuli or potentially damaging. And the force that is applied is that pressure and will end up overriding the pain. So Golgi tendon organs are activated to inhibit the muscle and decrease the injury. And when repeated consistently over time, we get overriding of the nociception, or that pain perception, and the inhibition decreases. So the Golgi tendon organs will start to adapt to a new length and tension. So now we've got lengthening of the muscles occurring over time. So that's another theory we have behind what's the physiology of our PNF stretching. All right, so we're going to take it home now with injury and inflammation and talk about like, what is this connection? What is this connection between when we have injury, when we have inflammation, and how does that lead us into our corrective exercise continuum, starting with inhibition and lengthening? So with injury and inflammation will cause pain, right? We have all of our bradykinin molecules, all of our prostaglandins that are all causing the pain stimulus to happen. And this will end up increasing muscle tension and muscle spasms. And it does it as a protective mechanism. So they're little microspasms. They're not like you all of a sudden feel your leg spasm, but it's happening at those muscle fiber cells. So we're getting a little increase in tension, a little increase in the muscle spasming that's happening in order to protect us because of the pain that we're experiencing. So it helps to just tighten up the area to make it less likely to get injured because I've got a little form to it with the muscles as stability. So when that happens, we get increased firing of the muscle spindles that can also, or when we get an increased stretch of the muscle spindles, it also creates this microspasming as well. When this happens, adhesions start to form on the connective tissue. So these little tiny adhesions are starting to form all over the fascia that we have, and it's kind of creating this inelastic matrix. So it's kind of like lattice that's kind of like spreading out and forming all over the place. And it's pretty weak. It's not strong in nature. But eventually it starts to form into a more permanent structural change. And that's when we start to have more issues. So Davis's law says that soft tissue will rebuild itself along the lines of stress with inelastic collagen matrix in a random pattern. It does not run in the same direction of the muscle fibers. It's kind of just in these random patterns, okay? So when soft tissue is rebuilding, so all of, the fibrous tissue, everything is rebuilding in this area that's not muscle or bone, right? All the fascia and all the other tissues that are surrounding it, connective tissue, it's all starting to rebuild itself in very tight, tough, inelastic, random patterns, okay? But what we can do is we can start to stretch it to try and draw it into the best line of function that is going to promote good movement. Because when it's just built as this random inelastic pattern, whenever we try to stretch it, it's not going in a certain pattern, so it acts as a roadblock. So we need to facilitate that. It's very much a corollary, if you are familiar with Wolff's Law, that basically says the more that you are impacting the bone, the more pressure you're putting on it, the more that it's going to build up again. And we kind of just looked at that when we were looking at our remodeling of the bone, right? So like the more pressure that I put, the more stress that I'm putting on the bone, the more it's going to rebuild. Well, when I'm trying to stretch it out, the more stretching that I do consistently over time will actually start to get those fibers running in the pattern we want them to in order to facilitate the best movement and ranges of motion. So let me ask you a question. We are flexion addicts. We really are. Right? We see all these pictures. You can kind of see them here when we're driving, when we're working at computers, when we're sitting at desks, when we're reading, when we're typing on our computers and eating and watching TV. We are always in this flexion, right? We've got flexion at the hips. We've got flexion at the knees. We've got flexion over at the shoulders, right? Our shoulders are flexed forward. They're rolling forward. My question is, how would reciprocal inhibition affect us in this situation? So I want you to think about this. So what did we know about reciprocal inhibition? Well, reciprocal inhibition is when we are contracting a muscle. And we talked about it with a painful stimulus, but remember, it also just happens when muscles are contracting. So when we are contracting our agonist muscles, what happens through reciprocal inhibition to those antagonist muscles? It relaxes them. Now imagine if we are always flexed. We are always contracting these flexor muscles of the hip, of the shoulders, rolling everything forward. Head flexion as well, right? Head's always brought down too. Well, what's happening is we are inhibiting messages to the antagonistic muscles, which means the whole posterior chain of our body. So I hope you can understand and appreciate that when we are constantly in these flexed positions, it is weakening the posterior side of our bodies. So we have two different syndromes that we can talk about when we start looking at this: upper crossed syndrome and lower crossed syndrome. So with upper crossed syndrome, we're just specifically looking up at the upper extremities and the head and the torso, right? So it's dealing with the shoulders. And what's tight? Well, what's tightening is we've got our pectoralis major and minor, our upper trapezius, as we're like hunching our shoulders higher up, including with our levator scapulae. That's also elevating the scapula. So you will see that hunching and like, that's when your shoulders are going up to your ears, right? With the elevation of the scapula. And also neck muscles that we have, including the sternocleidomastoid. Those all tend to be tightened because we are in this flexed position and constantly contracting them. And it happens kind of in this cross section, right? It crosses at the major joint that we have here of the neck. So we have tight in the front down here, tight in the back up here. And what that's doing is developing the antagonistic to be inhibited. So we get weaker lower trapezius and the serratus anterior, more weakness in the rhomboid major and minor, and also our deep flexor muscles that we have in our neck become weakened as well. So we've got this cross pattern that's happening between what is tight and what is inhibited and weak that's happening. So what do we need to do with this individual? When we look at the corrective exercise continuum, we're going to start with looking at inhibiting and lengthening these tighter areas. So we are going to inhibit through self-myofascial release or through massage therapy these tightened areas and work on stretching them out. And then we need to build up activation exercises in these areas because they're weakened. And so we'll have our activation exercises and then start to integrate as they become stronger. So here, we're going to do rolls of our pec muscles. We're going to definitely get into those upper traps. Those are usually a killer for people. Sternocleidomastoid, it's kind of hard. It's not hard. It's uncomfortable for people. It just comes down in the front of your neck, on the sides. It's kind of uncomfortable to massage, but if you have a good massage therapist, it can work as well. And so we'll be doing that and stretching out those neck muscles, stretching out those pecs, stretching out the upper trapezius by, especially doing like head tilts and using pressure and resistance to assist in that can help. And then what we're going to want to do is start activating the lower parts of our trapezius, our serratus anterior. Things that we can do is like low rows. So instead of coming up from a higher position where you're coming like from a row of above your head, you might be now activating instead a row that's coming out straight horizontal from you. And that's going to help with the rhomboids. You can also do, that's more of an integrated exercise, but you can do what are called scapular punches, in which you hold out your hands in front of you. I don't have that video on, I'm very sorry, but you hold out your hands in front of you, and then you like protract and retract your scapula back and forth to create this punching motion that you have. And that activates a lot of those, the middle and the lower trapezius, the serratus anterior, and the rhomboid major and minor. We also have lower crossed syndrome. And so this is more dealing around the hips. Again, it's a crossed nature where we're going to have tight areas going across in this cross pattern, and then it's going to balance itself by having this weaker areas that it's going to be inhibiting. So our tightened areas are like the iliopsoas, the rectus femoris, the tensor fascia lata, the adductor brevis, the erector spinae coming in the back. So we have a lot of lower back pain that can come with it as well. And when those are constantly contracted, it's going to lead to weaknesses in a lot of our core muscles of like our abs, so our rectus abdominis, the transversus abdominis, and the obliques, and then also in our glutes, so the glute max, med, and minimus. So this is our lower crossed syndrome in which we have tightened areas in the quads in the back, and then we have weaker areas in the abs or the core and the glutes, right? Which are also what I consider to be core muscles as well. So what would we need to do? We would need to inhibit the hip flexors through, it's hard to roll. You can get a good massage therapist, though, who can hit that iliopsoas. And then you can roll on the tensor fascia lata and the rectus femoris and the adductors. We try not to roll, we try not to inhibit and do self-myofascial release as far as rolling goes on the erector spinae, because you don't want to go right over the lumbar area. But if you can tilt enough off of it so that the lumbar spine, like the spinous processes, aren't on the roller, but the muscles are, that is very beneficial. And then we need to do more core activation exercises. We need to do some pelvic tilts. We need to engage those muscles. And then do a lot of clamshells and a lot of fire hydrants to activate those glute muscles, glute leg bridges, those types of things in order to build up and activate and start integrating into larger motions. So remember, we have our fascia that we have here, right? And we've got connective tissue fascia that is surrounding each individual muscle fiber within the fascicles themselves, and then within the muscle itself, right? And we've got this connective tissue, right? This fascia that is where all of this spasming is starting to happen when we are having the contractions that are occurring either through inflammation or through the injury itself. Right? So why do we use this myofascial release? Why do we do like foam rolling and other techniques like that? Well, what it can help do is it helps to release a lot of those microspasms within the muscle itself. These are often called the trigger points. You often hear about trigger point therapy, or if you're having trigger points, those are the microspasms that are occurring within the muscle. So it's like when you're going to roll and all of a sudden you're on a part and you're like, oh yeah, that's really painful right there. That's because that is where there's a lot of microspasming happening within the muscle and the adhesions are starting to build up there. So we want to actually break up those fascial adhesions in those areas. And that's what this foam rolling can do, or the myofascial release. And it actually starts to change the histological makeup of the fascia. So it like the actual like formation in the cells of the fascia, the microbiology of this starts to change. And it makes it more into a fluid tissue instead of a tougher viscous tissue. And it actually ends up normalizing the structure a little bit more, and then allows us to be able to combine that with stretching, because now we've normalized it, we've broken up some fascial adhesions, we've stopped some microspasming from happening. And what it does then is it allows our stretching to be even more powerful of a move. So, does foam rolling or self-myofascial release do anything with the muscle spindles? Well, we do know that sustained pressure to a muscle belly will habituate the muscle spindles, right? So when there's a sustained pressure happening at the level of the muscle belly, right, which is where we're doing our myofascial release, it will end up decreasing gamma loop activities. So that's nice for us. It helps us to release those trigger points. As far as what we're doing, we're trying to get ischemia, which is a lack of blood flow. It's actually a lack of oxygen because of a lack of blood flow, because of compression, right? So when we are putting ourselves on the rollers, or we're using a lacrosse ball or other types of techniques of self-myofascial release, or if somebody's doing it for us through myofascial release, like massage therapy or active release therapy, those types of therapies, we are putting compression on the muscle itself to cause a lack of blood flow. And we're doing this purposefully for a period of time. If it's really high intensity, we only want to do it for about 30 seconds or so. If it's a lower intensity, we can do it for about 90 seconds or so. So it depends on like how much pain is being instigated by the fascial release. Another way to do this same type of a thing is activating the area by using dry needling. Well, they're actually like put in needles. These are larger needles than acupuncture. You can actually do acupuncture as well. Acupuncture works really interestingly because what it does is the needle going in, or the probe of the acupuncture needle going in, changes the ions that are located in that area, and it draws more ions to the area, and it releases them also from the acupuncture needle itself. At least this is what my acupuncturist was informing me of. And so it actually changes up the ionic nature of that area that can help to cause relaxation then, because we've changed the ions that are flowing in that area. Dry needling does a similar thing. We're actually like pushing a needle like into the muscle where it is spasming until it can actually relax. So that's what the goal is of dry needling. All right. So looking at a case study, we've got somebody who's been having left hamstring pain and tightness for about 2 months now. Right? And what they noticed is that it starts to loosen up after about 1 mile of running or so, but it's really tight in the beginning. And their goal in coming to you is they want to eliminate that pain and tightness and improve their running performance. Okay, so we've got a lot of tightness happening in that left hamstring. What can we do? Well, good questions to ask would be things like, tell me about your warm-up routine, right? We're not diagnosing them, we're not treating them in this way, but we can get a picture of what's happening in their warm-up routine. Are they using foam rolling? And if not, then we should be teaching them how to foam roll and telling them where to buy a foam roller, right? So we're going to talk about like, where could we be doing this foam rolling? Where are the key areas that we really need to focus on? And we did a lot of this in strength training and conditioning instruction. If you haven't taken that yet, we will take a look at that in that class. So we're going to focus on things like the hamstrings. We can focus on the quads. We can focus on the adductors. The calves are a great place. What we've also seen as far as tight areas go already is like in the pecs and in the traps, the supraspinatus and infraspinatus also become really tight with the shoulder activity that we have within the flexion area a lot. So, and then we'll coach them on the duration and how often we should be doing it. So when we're coaching on duration, remember we're trying to like foam roll an area for about that 90 seconds or so. If we're too high intensity, don't hold it on anything for more than 30 seconds because it's just a little bit too harsh on it. And then we should be doing this on a regular basis throughout the week. And then we can consider that when they are cooling down, make sure to do a good cool down and a nice stretch after the workout. So if they're not doing it, we want to get them working on those things as well. So as far as foam rolling goes and some good directions to give, we kind of already talked about it. The sequencing, you can go really in any order that you want. There's not like you can go from head to toe, you can go from toe to head, you can just randomly do different body parts. There's no like evidence that's showing like what's better than the others. So you might want to just specifically focus on the area that you know is tight and get that taken care of. Or you might start at the feet and work your way up. You might start at the neck and the shoulders and the back and work your way down. It really doesn't matter as far as that sequencing goes. As far as the different tools that you can use, there are foam rollers that you have. You can do tennis balls or lacrosse balls. Tennis balls are just a little softer in nature. The lacrosse balls give it a little bit more effectiveness as far as having a harder thing to roll against. There's also like rolling sticks that they have created. There's like a PVC pipe with little sections of PVC piping all around it in little 1-inch sections. So it kind of like works like a conveyor belt almost, rolling up and down your body. You can also just rub, right? You have massage therapy, either through self-massage or going to a massage therapist. And the goal is to work an area until you start to see at least a 10% improvement. So you're going to be rolling in these areas. I'm going to roll out that hamstring until it starts to feel more loose. And it's a subjective measurement, but about 10% improvement in the range of motion because we're inhibiting those tight muscles. It may feel very intense, right? And especially when you get to those key trigger point areas, but you do want to be able to relax and breathe into it. So really encourage that. Try that relaxation. If you're contracting at the same time as when you're foam rolling or doing myofascial release, it is counterproductive. Doing frequent bouts is more effective than just every once in a while long bouts. So frequent short bouts, err on that side, doing shorter time periods but more often than just deciding to foam roll once every 2 weeks, right? You're going to get better consistency, better outcomes when you're doing it repeatedly every couple of days compared to when it's every once in a while but you spend a longer time on it. You really do have to consider your patient and what their ability is to use foam rollers or other types of devices. So asking an obese patient to get down and put their weight onto a foam roller will cause an extreme amount of pain. So watch for other ways to do it. Can you do it up against a wall? Putting like a tennis ball or a lacrosse ball up on the shoulder area to be able to work those trapezius by leaning against a wall. Excellent way to do it. Same thing with your pec muscles, right? And then when we're talking about like somebody who can't get down onto the ground or has too much weight that it'll end up causing them pain if they're putting their weight onto the foam roller, that's when the rolling sticks are better used because it's just you rolling with your hand strength and it's a good way to start out. So make sure that they can find positions that they are able to relax in, that's not causing them too much pain, and that they can be in for longer periods of time. So with just general fascial tension, you're going to roll through that tension, right? If it's just like, you're just rolling through areas that there's just a generalized tension and it's not too heavy of a tension, just roll through that tension. When you get to those specific tight spots or those trigger points, here's when you're going to want to hold it for at least 90 seconds. And you can at a lower intensity. And you can either do this by just like literally applying your weight in that area, or just do like little tiny micro rolls, just like millimeter. You're just moving like a millimeter back and forth in the different directions. If it's a very high intensity of pain, then we're going to only limit that. We're going to limit that to 30 seconds because it's just, we don't want to cause too much pain, right? But when in doubt, hold it for 90 if it's not causing too much pain. You can also do things like using active release therapy or active release technique, in which you are applying pressure in that area and then stretch it right away afterwards. Meaning not just like foam roll all over your body and then do a stretching session, but it's like literally foam roll that area, hold that for 90 seconds, and immediately stretch that muscle. So that's using the premises of active release techniques or active release therapy. Remember that we need to be breathing and relaxing during this time period because we cannot be contracting the muscles while we're trying to inhibit them. It totally defeats the purpose. Make sure they actually are finding muscle and that they're not rolling over things like bursa or bony areas or like the greater trochanter. If it's excruciating pain, not a soreness, but like a ow because you're on a bone, make sure that's not happening because it actually can cause a lot of inflammation when you're going over the bursa or other bony areas, and we don't want that to happen because it's just going to perpetuate the inflammation cycle and cause more tightening and microspasms within the area. So that's what I have for you guys as far as this goes. Thank you for joining me.